My name is Nathan Williams. I'll be presenting returning from an Achilles tendon injury or rupture here at Jacksonville State University. This is HPE450 research seminar. Introduction. The Achilles tendon is largest and strongest in the body and is shared by the gastrocnemius and soleus muscles of the posterior leg. It connects the two muscle groups of the calcaneus. Overstretching the Achilles, it can tear or rupture. The Achilles tendon is susceptible to injury or damage due to overuse or overload. Roughly 60 to 75% of ruptures take place in sporting activities like basketball or soccer. And this picture here just shows these muscles that make up the Achilles tendon, or that make up the mechanism of the tendon. And this area here is actually the actual tendon that runs up to the back of the soleus. Injury prevention. Preventing injury to the Achilles tendon can be as simple as stretching calves and lower leg muscles with toe and heel raises. Body mass index also plays a crucial part in many Achilles injuries. It's found that body mass index really is a pivotal role in determining Achilles health. Maintaining a healthy body weight and mass index can prevent Achilles tears or ruptures. Heat therapy promotes blood flow. So before exercising, getting good blood to the Achilles to help prevent injury. And then cold therapy helps the buildup of inflammation. So using cold compresses and elevation after exercises can help tissues heal properly. The tissues in the Achilles are very susceptible to lesions and adhesions, and that, like I said, that has to do with body mass and body weight in that area. So those things can really help with injury prevention. Injury mechanism. Because of the tensile load on the Achilles, it can be damaged, torn, or ruptured in many different ways. As mentioned before, there are many factors that contribute to the integrity of the Achilles. The age, weight, your body mass, blood flow, muscle tightness, hydration level, and many other things. But like I said before, the main thing is body mass index and also the rate of exercise. I mean, the Achilles is one of those things that the more you work it out, the older you get, it's probably more susceptible to damage. Achilles injuries on average occur in athletes ranging from 27 to 40. I happen to be one of the few people that falls outside of that. The Achilles can be torn, ruptured when running or accelerating, jumping, landing, or even just twisting the ankle. Especially in older patients. Many people, older people that just go walking in their neighborhood or something like that, they step in a hole or step off a curb the wrong way and twist their ankle a certain way. That mechanism, the way that it's done, depending on how it happens, they can tear their Achilles. Some of the surgical repair approaches. An open repair is when the tendon repair is performed through a 3-inch incision running down the back of the ankle over the site of the rupture. And each end of the tendon is sewn down with a suture and tied together with the ankle in a 30-degree plantar flexion position. This allows for the Achilles to relax under normal tension, and the ends are touching one another. In the percutaneous repair, a small incision is made approximately 1/2 inch over the rupture site, and the Achilles is attached to the gliding sheath and a special tool that is used to pass sutures through the tendon and into the sheath. Doing that uses needles that pass through the skin without making an incision, running down the length of the tendon. The percutaneous open repair is a modification of something called the Bosworth technique, and the Bosworth technique has been modified by passing the gastrosoleus flap percutaneously through the distal stump, and it eliminates 1/3 of the distal incision. So it it's a less invasive surgery, and yeah. So this chart here is part of the Andrews Sports Medicine rehab protocol when it comes to the Achilles tendon, and it just lays out a timeline of what a patient is meant to do throughout the days following a procedure. So we're going to go through these real quick. The first phase is tissue protection. So days 0 to 3 are when patients are using crutches with no weight. They'll still be on or in a splint in 30-degree plantar flexion, and they're supposed to avoid NSAID pain relievers, and it says a boot, but the boot probably won't come until a few weeks from here. And then in the rehabilitation stage, relative rest. The RICE principle is used here: rest, ice, compression, elevation, and the pain meds are really just for pain control, because the biggest thing with the Achilles in this stage is protecting the incision and making sure that there are no clots forming in the leg, because there will be no motion throughout this time. Okay, days 4 through 7, still tissue protection. May start putting weight on the foot, so it's going to be very, very lightweight. It's to tolerance. So the first few days of using the crutches with weights, and it says days 4 through 7. This is post surgery, out of the splint, out of a cast, and they'll be putting anywhere from, I think, 5 to 10 pounds, and then to 25% to tolerance. The same thing. Relative rest, removing and dressing the incision site every day, and then taking pain medications as needed. Days 8 through 14, a couple weeks after surgery, still weight to tolerance, and then they may put them in a boot at this time. But like I said, it's to tolerance, and they'll go back to different stages if pain persists. Weeks 3 to 4, we'll go straight to the boot, but again, it'll be to tolerance. They're only going to be doing walking in a boot to tolerance. Okay, and it says avoid eccentric exercises or eccentric exercises. They're not going to be moving their foot in dynamic motions, and they're not going to perform plantar flexion or excessive dorsiflexion at all. They progress to weight-bearing activities in therapy. So they'll start their boot wean protocol, trying to get out of the boot in about 6 weeks. And then they'll start low-impact exercises, stationary bike, it says here. But again, they're going to want to avoid excessive dorsiflexion while on a bike. Weeks 5 to 6, still in a boot, crutches to tolerance, and they're going to avoid the eccentric exercises still. And it says to avoid walking bare feet. At this time, they're going to be in the boot with something called a heel raise or a heel lift. That's still keeping their foot in a 30-degree plantar flexion position. Week 6 to 12, they're no longer going to be using ice, and they're going to avoid using heat if there's still pain, and they're still going to be using this heel lift here. But they're going to be doing things like 4-way ankle pumps, weight shifts, and begin working on their gait to tolerance. Okay, and then months 3 and greater, they're going to reassess. They're going to have follow-up appointment, reassess the Achilles, and then begin more dynamic exercises when it comes to the foot. Now, this is a very progressive protocol. Most Achilles protocols now are very conservative in that they will not even begin running progressions until 6 months out. Rehabilitation protocol. Rehabilitation of the Achilles is a very conservative and gradual process. Weight-bearing schedule can span anywhere from 4 to 6 weeks post-repair. So those first 2 weeks will be no weight-bearing. The next 2 weeks will be in a cast. The next 2 weeks after that will begin a boot and a boot wean protocol. Patients will then begin therapy sessions up to 3 days a week. That's the optimal timing. Patients will begin weight shifts to tolerance, balance exercises to tolerance, as well as cold therapy to decrease adhesions in the Achilles. At this time, like after they've come out of the boot and everything, they'll begin walking exercises to work on their gait, to reintroduce, those muscles to proper gait, and then heel to toe exaggeration is part of that. And then balance exercises and toe raises may be attempted to tolerance as well. Patients may notice increased heel discomfort and pain in the lower leg. This is normal. When you go 6 weeks without walking on your foot, and then all of a sudden you're walking on your foot every day, that heel is going to be really mad at you. Achilles tendon rupture patients must be aware that the tendon is extremely susceptible to re-rupture in the following months after repair. And they may begin jogging or light running progression 6 months post-operation. And like I said before, that is a very conservative time frame. It can be found that anybody can begin running progressions 4 to 5 months after. And if no pain is experienced while attempting pre-injury motions, such as exercises, their normal exercises like they would do in practice, they may return to play as early as 8 months post-operations, being wary of their limits. Because the Achilles, like I said, is very susceptible to re-rupture after repair. Return to play percentages for Achilles athletes are 61, 62, and 65.6% for professional basketball, baseball, and football player athletes, respectively. Returning to prior peak performances following an Achilles rupture is rare. And in the NBA, these Achilles ruptures happen to players 28 and up on average, and in their 7th season. So, like I said, this picture here, Kobe Bryant tore his when he was 34, and came back, and his numbers weren't quite the same, but it's Kobe, so it's just a different athlete in general. Conclusion: the Achilles tendon is the strongest tendon in the body. However, it is also the most injured tendon as well. The Achilles tendon is ruptured. It may require surgical repair. Now, there is a non-surgical repair, but that is normally for younger patients or very much older patients. That approach is very conservative in that if the Achilles is not repaired surgically, there is more chance for it to be torn. Okay. The Achilles has poor blood supply and must be properly tended to following surgical repair and rehabilitation. Return to play can take anywhere from 8 to 12 months, and performance may never return to its peak. And then our references.